Alright guys, so today we're going to try to tackle the beast that is heart murmurs. This is brought to you by Dirty USMLE. In this video, we're going to simplify everything. First, we're going to start with basics of where to place your stethoscope, because that comes up on your exam. Then we're going to talk about how you can figure out which murmur you're listening to simply based on the description of systolic versus diastolic. Then we'll jump into some specifics about what makes murmurs louder and softer, and then we'll finish up with some beautiful mnemonics that will give away buzzwords to help you remember what murmur they are talking about on your exam. So let's get started with the auscultation. So there are 4 very distinct locations where stethoscopes get placed, and what might happen on your exam is that you'll be given the location of where they're auscultating these murmurs. So the mnemonic for remembering these positions is apartment M. We filled that in here. APTM, apartment M. The right second intercostal space is known as the aortic area. The left second intercostal space is known as the pulmonic area. The left fourth is the tricuspid area, and then you have the apex, which is the mitral area. So get this down and commit this to memory first. This is good not only for exams, but also for when you enter your clinical rotations and start to have to, know where to place your stethoscope when you're actually listening to somebody's heart. Now I want to transition now and kind of use an example to show you how to figure out what the murmur is simply based on a few clues in the description. So here's an example. A 78-year-old male presents complaining of dyspnea on exertion and exertional angina for the past 3 months. On exam, you note a 2 out of 6 systolic murmur when your stethoscope is placed in the apical area. Which of the following is the correct murmur? So this is much simpler than it needs to be. People get really overwhelmed when they get murmur questions, but let's simplify this. Basically, you need to look for a few things. One, is the murmur systolic or diastolic? And where is it occurring? If you know those 2 pieces of information, you can solve the murmur without any other clues. You don't even have to listen to the audio file to see what the murmur sounds like. In this question, they told us that it's a systolic murmur and it's in the apical area. So you can see in the top left here, I included our diagram with our 4 different auscultation spots. So we know that we're in the apical area. So we know this has to be a mitral sound. Now the question is it mitral stenosis or mitral regurgitation? So starting from the ground up here, if you knew of the apartment M mnemonic, you would already know this has to be mitral. So you've got part 1 of this question solved. Part 2 is it mitral stenosis or mitral regurgitation? And that's where the systolic versus diastolic part comes into play. So now you have to ask yourself, what happens at the valve during systole versus diastole? So we're talking about the mitral valve, and we know that during diastole, blood is going to flow from the left atrium into the left ventricle and fill during diastole. But in systole, blood is going to be ejected out of the left ventricle, and it has the potential of going back across the mitral valve if it's going to regurgitate back into the left atrium. So I've kind of already given it away here, but basically we know that we're talking about a systolic murmur, and the only time that a murmur occurs on the mitral valve during systole is during mitral regurgitation. Again, if it was mitral stenosis, it would have to be a diastolic murmur, because the only time that you hear mitral stenosis is when blood flows across the mitral valve when the left atrium is trying to throw blood into the ventricle as it fills that ventricle. So I want to take a step back here and make sure that you're up to speed. First, you have to know the APTM, apartment M mnemonic. That tells you where the murmur is located or what area we're listening to. Then you have to ask yourself, what happens at that valve during systole versus diastole? And if you know all of that information, you can solve what the murmur is based on just those 2 pieces. You don't have to even listen to the audio file. So it's a really nice trick if you can get that down and understand the basic physiology about what happens at the valve in systole versus diastole. Now, with that in mind, this is the basics, the absolute basics that you need to know, the systolic versus diastolic murmurs. What I recommend is that you pause the video right now and ask yourself, what happens at the aortic valve, what happens at the pulmonic valve, what happens at the tricuspid, and what happens at the mitral during systole versus diastole. If you can understand whether blood is going to be ejected or going to be filling a ventricle, then you will be able to solve almost every question. If you're ready to move on, we're going to now talk about what makes murmurs louder or softer. And this is usually what people get tripped up on, so it's very important that we get a few things down. First is that during inspiration, right-sided murmurs get louder, and during expiration, left-sided murmurs get louder. This is just a general rule, and I need you to memorize it because it's going to go a long way for you. So what I always remembered was rinspiration and lexpiration. Left-sided gets louder during expiration, and right-sided gets louder during inspiration. This is something that you absolutely need to memorize. I wouldn't even think about why, just memorize it. The more confusing topic is what happens with preload versus afterload. So we're going to spend quite a bit of time on this slide. So I really want to make sure that you understand this. When you increase preload, basically what you're doing is pushing more blood back to the heart. Therefore, as more blood flows over valves, the murmurs become louder because more blood is going to flow over them. So as an example, if you usually have a mitral stenosis, the more blood that flows across that mitral valve means that that murmur is going to be louder because more blood is going to flow through an already stenotic valve. So if you're auscultating it, it will be louder, aka worse. The exception to this rule is hypertrophic obstructive cardiomyopathy and mitral valve prolapse. This is a very high yield concept, so I'm going to explain this. When you have hypertrophic obstructive cardiomyopathy, or HOCM for short, the heart becomes hypertrophied, and the septum kind of bulges and blocks the outflow tract. So, normally, more blood flowing across a valve or into the heart makes murmurs louder. But in the case of HOCM and mitral valve prolapse, which is lower yield, but still we include it in this discussion, more blood in the heart actually pushes that septum back into its normal physiologic position. So in HOCM, if you can envision this diagram in your head, the more blood or the more pressure on that septum pushes it back into its normal position and reopens that outflow tract. So generally speaking, anytime you increase preload, which you do via squatting or leg raising, more blood is going to flow through the heart. And anytime more blood flows over a valve, whether it's stenotic or regurgitant, you're going to get louder murmurs. The only exception to this rule is HOCM and mitral valve prolapse. In HOCM, it's because more blood pushes the septum back into its normal position, which is the picture all the way on the left. And in mitral valve prolapse, it's because the mitral valve is literally prolapsing and it's blocking normal blood flow. So I want to simplify this to the most basic level. You don't need to understand what's happening with the mitral valve. You'll never be asked that. But just think of it as more blood going through the heart and returning the mitral valve leaflets back into their normal position. That's all you need to know. So again, I'm going to summarize. More blood, more preload, every murmur gets louder. The only exceptions are HOCM and mitral valve prolapse. HOCM because you reopen up the outflow tract obstruction, and mitral valve prolapse because you return the valves back into a relatively normal position where you don't hear the mid-systolic click that goes along with mitral valve prolapse. That's increased preload. Now let's jump to the other side of the slide here. If you decrease your preload, your murmurs will get softer, and it's the same exact reasoning, right? Less blood going back to the heart means less blood is going to flow across a stenotic or regurgitant valve. Therefore, the murmurs will be softer, aka better, right? They're not going to sound as loud, they're not going to sound as bad because less blood is flowing over the abnormal valve. Again, the exception is HOCM and mitral valve prolapse, again for the same reason. So in HOCM, if you look at our picture on the left here, you see the normal position of the heart, but then the image just to the right shows the heart with hypertrophic cardiomyopathy. If you have less blood flowing through the heart, then less blood is there to push that septum back to its normal position. So HOCM sounds worse. In mitral valve prolapse, you have less blood to return the mitral valves back to their normal position. When you Decrease preload, you do that via Valsalva. So you bear down. It's like telling a patient, I want you to bear down and pretend like you're having a bowel movement. This prevents blood from returning to the heart, aka it decreases your preload. So that's everything you need to know about preload, right? Think about preload as the amount of blood that gets loaded into the right atrium, aka the amount of blood that is returning to the heart through the venous system. Now I want to talk about afterload. Afterload is basically the pressure against which the heart pumps. So increased afterload means more pressure is being exerted upon the left ventricle as it tries to eject blood out of the heart. You can increase your afterload by doing something called hand grip. So when you're examining a patient, if you ever want to have them do hand grip, you're going to tell them to squeeze their left hand. And that hand grip is going to increase afterload, right? It's going to increase the pressure against which the heart has to pump. Now, usually when you increase the afterload, you get louder regurgitant murmurs. Now, why is that? Well, if the heart has to pump against a greater pressure, that means there is more pressure forcing blood backwards, right? Normally blood is going to pump out of the heart, but if it's pumping against a greater pressure, then you can think of it as more pressure being exerted upon the heart, which is going to try to force blood backwards. And that's exactly what a regurgitant murmur is, right? Blood is going to accidentally flow backwards in the wrong direction back over the valve. So when you increase afterload, the regurgitant murmurs become louder. Likewise, when you increase afterload, you're going to get a softer hokum and a softer mitral valve prolapse. And this is the same reasoning as before. If we increase afterload, then hokum has more pressure propping that septum back into its normal position. The mitral valves have more pressure propping them back into their normal position, those valve leaflets. So again, a softer hokum or a softer MVP is really saying that the murmur is getting better, right? It's getting softer. You don't hear it as much because there's less of a mechanical issue since there's more pressure returning the heart to its physiologic position. And that's really important to understand. The last thing I want to talk about is decreasing afterload. You can decrease afterload by using a drug called amyl nitrite. And this is probably the lowest yield of anything on this slide, but I include it for completeness sake here. If you decrease your afterload, hokum gets louder, right? Less pressure is forcing that septum back into its normal position, so the outflow tract gets obstructed and the hokum murmur gets worse, aka louder. If you decrease your afterload, you get a louder MVP. Again, same reason. Less pressure is being forced upon those mitral valve leaflets, which means that the mitral valve is going to prolapse more and get worse or get louder. So again, this slide is talking about preload versus afterload, how we change preload, how we change afterload, how we make it increase versus decrease, how you do that with Valsalva, squatting, leg raise, all this stuff. It's very high yield. The reason that this is important on your exam is that they'll give you a murmur and they'll tell you what, they'll say that the patient bears down, what do you expect to happen? Something like that. They want to make sure that you can understand the physiology of what's going on in the chambers of the heart and how that changes the strength of the murmur that you're hearing. The other thing that I want to point out is that hokum, because it's such a high yield exception, and again, it's way more high yield than mitral valve prolapse, hokum can sound like other murmurs, but the way that you differentiate them is based on what it's doing with these maneuvers. So if you want to distinguish hokum from something like a ventricular septal defect, they'll tell you what's happening with the murmurs. So keep this in mind. It's very high yield. Now what I want to get into is the last section of this video. This is going to be a rapid review of high yield associations and buzzwords that can help you get the murmur right. I've included a lot of my mnemonics here that helped me on my exam pretty extensively. And I would say that I usually was getting between 90 and 100% of the murmur questions correct just because I had these in my back pocket. So up to this point, you should understand normal physiology. You should understand the APTM locations and systolic versus diastolic, what's happening across that valve. You should understand how maneuvers change those murmurs. But if all else fails, if all of that normal physiology that I just explained is not enough to get you the answer right, well, fear not, guys. I've got some pretty sick mnemonics for you, so let's get into them. The first is aortic stenosis, and I would consider aortic stenosis to be probably the highest yield murmur that shows up on exams. This is known as a crescendo-decrescendo murmur, which means that the murmur gets louder towards the middle and then softer, so it kind of increases and then comes back down. There are two presentations for aortic stenosis. One is going to just be an old patient. If you have to take an absolute guess on your exam and you have a patient who's, let's say, 70 years or older, it's most likely aortic stenosis because over time, with all of the changes that happen as you age, that valve just breaks down. Hypertensive hearts and remodeling of the heart really leads to a lot of pressure going through that valve, and it causes an aortic stenosis. And what they say is that patients are SAD. They get syncope, angina, and dyspnea, right? So dyspnea, angina, syncope. Remember that old patients are SAD. Aortic stenosis is SAD. The other thing that you should keep in mind is that it's possible to have basically a functional aortic stenosis through a calcified valve. So if any patient has really high calcium levels, you can actually deposit little calcium crystals around the aortic valve, and because crystals accumulate around the valve, it's decreasing the space that blood has to pump through the aortic valve, which creates a functional aortic stenosis. So again, aortic stenosis, two presentations: anyone who's old and SAD, and the other person who has little calcification of their valve. The other thing that I want you to remember about aortic stenosis is that it radiates to the carotids. And the way that you can remember this is that I take the letter A for aortic stenosis and I draw the up arrow and the down arrow, which reminds me that it's crescendo decrescendo. The up arrow also reminds me that it radiates up to the carotids. So if you remember where the aortic area is on our kind of rib cage diagram, that up arrow points right at the carotids. So aortic stenosis, old and SAD, crescendo decrescendo, radiates to the carotids. If you do have to listen to it on your exam and it sounds like it gets louder and then comes back down, that's aortic stenosis. That's crescendo decrescendo. And what you see at the top here is just the kind of diagram of the murmur based on what it sounds like. So again, aortic stenosis, crescendo decrescendo. Mitral regurgitation is a holosystolic murmur. So it's usually about the same volume throughout, but it doesn't stop. It's holosystolic. It's present for all of systole. So between S1 and that should say S2, you hear continuous murmur. The mitral valve is usually implicated if the patient has a history of rheumatic fever. So the mnemonic is rheumitral. Anytime they have a history of rheumatic fever, think about the mitral valve. That is the number one valve that gets involved. Mitral regurgitation radiates to the axilla. That's important and it's high yield because sometimes they'll tell you about the murmur and say that it's radiating and they'll give you the direction of the axilla. So again, rheumitral, very important. That's mitral regurgitation. Tricuspid regurgitation is very similar. It's also holosystolic. Between S1 and, again, that should say S2, it's there the entire time. The tricuspid valve is always damaged when you have patients who have a history of intravenous drug abuse. So my mnemonic is, do you want to try some drugs? I want you to think about the tricuspid murmurs, whether it's regurgitation or stenosis, whenever you have a patient who has any risk factors or history for IVDA. So, patients with HIV, hepatitis, obvious intravenous drug abuse, anything that points to them being a former drug abuser, immediately think tricuspid valve. The reason that this is because the first valve that blood flows across when it reaches the heart is the tricuspid valve. So if you have blood that's littered with pathogens as a result of intravenous drug abuse, the damage is going to be primarily concentrated at the tricuspid valve. So, want to try some drugs? That's tricuspid regurgitation. Aortic regurgitation is described as an early blowing diastolic murmur. So you see S1 and that should say S2. It's very early in diastole, right after S2, and it's described as a blowing murmur. Patients will present with aortic regurgitation when they have connective tissue diseases or Marfan's. So these basically cause deposition or destruction of the connective tissue around the aortic valve, and it kind of blows open that valve and creates a regurgitation where blood flows backwards across the valve because it loses the integrity that the valve normally has, and therefore it can't close properly. Something that's not on this slide that's also very important is that patients with aortic regurgitation have something that's known as head bobbing. Because of the volume of blood that gets pumped back across that valve, there's a very large difference between the pressure during systole and the pressure during diastole that's going across that valve. And because of this, you get some really unique symptoms. One is head bobbing. So anytime you see a patient head bobbing, the answer is aortic regurgitation. Don't think too much about it. It's aortic regurgitation. The other high yield findings are what's known as water hammer pulses and femoral bruits. I can't really explain why femoral bruits happen. I would just memorize it, although it's the lowest yield of these three peripheral symptoms of aortic regurgitation. But the water hammer pulse, it's really easy to understand if you just think about it. So let's take 30 seconds because it's high yield. When you have aortic regurgitation, blood gets ejected over the aortic valve out of the heart and goes to the rest of the body. However, what happens in aortic regurgitation is blood then regurgitates or goes backwards, back over the aortic valve and back into the heart. This is during diastole. So the systolic pressure is pretty high because it's ejecting a large volume of blood out to the rest of the body. But the diastolic pressure is very low because the regurgitant blood is flowing back into the heart, and therefore the diastolic pressure in the rest of the body is significantly low. So water hammer pulse describes a pulse that is really strong during systole but then collapses during diastole. And that is exactly because of aortic regurgitation. You're ejecting a huge pool of blood that was previously regurgitant, so you built up blood. But then during diastole, it collapses because what should come out during diastole is actually regurgitating backwards. So that's known as a water hammer pulse. So to summarize aortic regurgitation here, think of regurgitation, aortic regurgitation, anytime they describe the word blowing, anytime you see head bobbing, or anytime they refer to anything as a water hammer pulse. That's aortic regurgitation, and the mnemonic is, are you gonna blow me? Because AR for aortic regurgitation, and blow reminds you that if they say it's a blowing murmur, it's aortic regurgitation. So very high yield murmur, lots of different peripheral findings. That's aortic regurgitation. Mitral stenosis is a very high yield murmur because of the description. It has what's called an opening snap. That's super high yield, and we'll come back to that in 1 second. But again, we're talking about the mitral valve here. So anytime a patient has a history of rheumatic fever, think rheumitral. It's always going to be the mitral valve more often than not. This opening snap is really high yield, and my mnemonic for remembering this is that the operating system is Microsoft. That is to say that the OS is MS. The opening snap is mitral stenosis. So anytime they describe an opening snap, it's going to be mitral stenosis. And the reality of this is that it's really hard to hear an opening snap when you're actually listening to an audio file. So if they want you to pick mitral stenosis, they're usually going to include the buzzword opening snap. That could change, but that's what I would remember. So again, the operating system is Microsoft, aka the OS is MS, aka the opening snap is mitral stenosis. The next murmur we're going to talk about is HOCM, hypertrophic obstructive cardiomyopathy. And we already went through this pretty extensively on the slide about maneuvers and how they change murmurs. But anytime a patient has a family history of sudden cardiac death, I want you to think about HOCM. So patients that are dying in their 20s or 30s while they're exercising, the reason that that happens is that, again, in HOCM, the outlet is obstructed and you get functional heart failure because the heart is unable to pump blood to the rest of the body, and one thing leads to another, and patients die during exercise when increased demand is placed on their heart. So just to go through this one more time, HOCM is going to be similar to other murmurs by the way that it sounds and the location in which you hear it, but how it changes during maneuvers gives it away. So it gets louder or worse with decreased preload. So less blood going to the heart means that the septum can push over more and obstruct more, which makes the murmur louder or worse. It gets louder or worse with decreased afterload. So decreased afterload means less pressure forcing that septum over, which means the septum is going to block the outlet. So the murmur gets louder or worse. HOCM gets softer, aka better, with increased preload. So you want to increase your preload, have the patient do some leg raising or some squatting, get more blood going back to the heart. More blood in the heart is going to force that septum, push it to the side, and make the murmur better or softer. And lastly, the murmur will get softer or better with increased afterload. So have the patient use some hand grip, squeeze their left hand, You're going to make the heart have to pump against a greater pressure, which means more pressure is going to force that septum back into its normal position, which makes hokum sound softer or better. The last murmur we're going to talk about is mitral valve prolapse, MVP. So mitral valve prolapse is high yield for a few reasons. One is that it has something called a mid-systolic click. Anytime you have a young woman with a psychiatric history, I want you to think about MVP. We're still trying to understand the relationship between psychiatry and cardiology, and it's very, very extensive. However, usually patients with MVP are young women who are anxious or depressed. Don't ask me why. I cannot tell you why, but that is the association. So keep that in the back of your mind. MVP can be caused by myxomatous valve disease. I'm throwing that in here because anytime they talk about this, I want you to think about the mitral valve. Think about MVP for myxomatous valve disease. And my beautiful mnemonic to remember MVP is that to win MVP, your team has to click. So that mid-systolic click is found in MVP, or mitral valve prolapse. That's it for this video. There are a few murmurs that I did not include because there's not much that you need to know about them. Those would include a PDA, a VSD, and an ASD. If you're confused about those murmurs, I recommend Googling them and learning the few basics that you need to know. But for the purpose of this discussion, I left them out because there's not much that you need to know about them, and there is one buzzword that can summarize most of them, so I don't want to waste your precious brain space. This has been Heart Murmurs. Good luck.